Chiropractic in the corporate setting. A growing trend is for big business to offer chiropractic services to their employees as part of their overall coverage. Unique to this trend is the integration of chiropractic services at on-site health centers. Piloted by several companies, this approach is in a demonstration phase where the feasibility is being tested. Companies are attempting to address the financial viability, employee satisfaction, and comparative effectiveness of this approach through data analysis. Certainly one obvious aspect of this data is utilization. If the services are offered, do employees utilize them? Secondly, do they opt for on-site versus off-site services that are similar, and are on-site services more effective? Next, does utilization of other health services decrease as a result of on-site utilization, saving money for the company? A recent study published in the Journal of Occupational and Environmental Medicine attempts to begin to answer some of these questions. It's entitled Value of Chiropractic Services at an On-Site Health Center. The researchers take the first year when chiropractic services were offered at an on-site health center and measure several things: utilization, comparison of utilization for chiropractic services between on- and off-site facilities, and they make some attempt at measuring effectiveness for the on-site group. The company at which chiropractic services was integrated and measured is Cerner. If you're not familiar with Cerner, they represent one of the major players in electronic health records. Ironically, as we'll see, they provide these systems of healthcare management to hospitals and for companies that have on-site integrative health management programs. The irony is that for such a robust health management expertise, the data in this study is far from robust. Cerner has what are called associates, totaling 8,500 associates with 11,600 lives covered, 5,530 associates and 6,070 dependents. They have 2 on-site health centers that provide a wide range of worksite healthcare benefits for their employees and their dependents, including chiropractic care. The services offered include primary medical care, pharmacy services, health coaching, and condition management counseling. Chiropractic services were introduced in 2010. So specifically, what was the intention of the current study? The researchers state that they wanted to determine whether chiropractic care provided at the on-site health centers versus care provided off-site by field practitioners was associated with lower utilization of healthcare visits, fewer radiology procedures, and a reduction in pain-related medication use. The second intention as a sub-analysis was to assess the effectiveness of on-site care through functional measurement tools. So how was data acquired? A retrospective claims analysis was performed for the year 2010 to evaluate healthcare utilization trends for patients who received chiropractic care at either the on-site health center or at off-site community-based chiropractic offices. Remember, this was the first year chiropractic services were offered, so there may be some lag time between switching to these on-site services for those already seeing an off-site chiropractor. This is in fact reflected in the group numbers. So let's stop for a moment and remind ourselves that a retrospective study does not look at cause and effect, but looks for associations and makes statistical inference for an association between or among selected factors. Also remember that there is no control group to compare natural history to when evaluating effectiveness. Let's review the procedures for the average patient encounter, starting with the office visit. The first visit lasted about 45 minutes. The first examination included a history of present illness, a functional assessment, any regional physical examination that may have been indicated, performance of orthopedic and neuromuscular examinations related to the area of complaint, a report of findings, and if consent was given, treatment. Subsequent visits included a brief history regarding the condition and any symptoms since the last visit, the chiropractic examination, and, if appropriate, treatment. For patients treated on-site, they were instructed to complete a functional assessment questionnaire appropriate to their care at each visit. The 3 that were utilized were the Headache Disability Index, the Neck Pain Disability Index, and the Oswestry Low Back Pain Questionnaire. To qualify for inclusion in the sub-analysis of on-site chiropractic care, patients had to complete a functional questionnaire at least twice during their study period, which stated another way means that although patients were supposed to complete questionnaires at every visit, not all did, as we'll see later. The researchers used a statistical approach that's used in regression analysis. The Poisson regression analysis estimates whether the number of events per patient differs between the two groups, and the zero-inflated Poisson regression analysis, which statistically estimates whether the odds of having a particular event differs significantly between groups. Now, the results indicated that the average total number of healthcare visits, radiology procedures, and musculoskeletal medication use per patient per visit was significantly higher for the off-site group. But let's look more closely at what the results actually suggest. The researchers state that using the zero-inflated Poisson regression analysis, patients were more likely to have at least one physical therapy visit and outpatient visit. That doesn't mean they did. This is a predictive analysis that proposes the odds that something will happen. They also state that the likelihood of having other healthcare events, such as radiology procedures and medication use, for example, were similar between groups. There are some clear differences between groups, the most obvious being the number of patients in each category. There were only 309 patients in the off-site group, but 858 patients in the off-site group. Other differences were that the on-site group was generally younger and had fewer women proportionately. Unfortunately, only the on-site group filled out outcome measures. Given the restriction that they had to have filled out at least 2 questionnaires, there were only 12 who filled out the headache disability questionnaire, 40 who filled out the neck disability questionnaire, and 74 who filled out the oswestry low back disability questionnaire. Now here's a major disappointment. The only way to know whether a decrease in disability measured by these questionnaires is significant and meaningful to the patients is knowing where they started from. If they had minimal disability at the beginning, then changes are perceived differently than those with severe disability when measured as a percentage. The researchers did not provide the baseline comparison, but only the mean differences. For the headache disability percentage decline, it was about 19%, and for the neck and low back disability percentage decrease, the mean difference was about 15%. But compared to what? Not having the baseline comparison numbers, we don't know how clinically relevant this change is. Additionally, the standard deviation is quite wide on all 3 measures, and confidence intervals range widely for the headache disability questionnaire from about 12 to 50%. Do you find it ironic that a company who specializes in health information management can't provide data that's more robust? So much is missing here, both in design and in data. So what's needed? A larger study with all data provided, including better defined patient presentations so that we know what type of headache or back pain the patients had and whether there were any differences in response based on that diagnosis. We need baseline comparisons for outcomes so that any change is seen in light of the severity of that disability. We need a cost analysis demonstrating the cost for, let's say, an average visit compared to that of an average for off-site care. Similarly, the cost for comparable radiology and other services should be measured. Patient satisfaction data is important because perhaps the convenience of on-site care is valued and influences patient satisfaction and possibly outcomes. And certainly we need utilization rates compared to other providers to see if this program is appealing to employees. Although it has its flaws, this study attempts to measure the effects of a growing trend in corporate healthcare, offering an integrative healthcare facility on-site. What will likely follow are larger, more robust studies that take full advantage of the electronic healthcare records available and hopefully enlighten all of us to the effectiveness and value of this intuitively attractive idea.